السلام عليكم ورحمة الله وبركاته. اليوم إن شاء الله راح نكمل pharmacokinetic. Today we are talking about metabolism of drug. So, for drug clearance through metabolism, once a drug enters the body, the process of eliminations begins. So, route of eliminations could include hepatic metabolism, elimination in bile, and elimination in urine. So metabolism leads to product with increased polarity, which allows drug eliminations through these different routes: hepatic or elimination in hepatic metabolism, or elimination in bile, or elimination in urine. That is, at any given time, a constant fraction of a drug present and eliminated in a unit of time. So most drug eliminated according to first order kinetic. So clearance is the amount of a drug cleared from the body per unit time and is calculated as, so clearance equal to 0.69 by apparent volume or apparent distribution divided by half-life of drug. And you know, T half, it is the elimination half-life of a drug. PD is the apparent volume distribution, and this number 0.69 is natural log constant. For drug half-life is often used as a measure of drug clearance because for many drugs, apparent volume of distribution is a constant. And we can calculate the clearance of a drug by using this equation if we know the apparent volume of drugs and the half-life for the drugs. Elimination half-life for the drugs. Now we are talking about metabolism kinetic. It is divided to two kinds of metabolism regarding the kind or the concentration of the drug. Some of these kinetic depending on the concentration of the drug, and other one is not depending on the concentration of the drug. For first order kinetic, what is first order kinetic? Is the rate of drug metabolism and elimination is directly proportional to the drug concentrations. While zero order kinetic, and at the same time is called, we can call it non-linear kinetic for some drugs such as aspirin, ethanol, phenytoin as example. The rate of metabolism or elimination is constant and does not depend on drug concentration. And in this case, drug does not depend on drug concentration. Now, we have what is called Km, which is Michel constant, the substrate concentration at half maximum velocity. And most of the reactions, that means the kinetic reaction, especially first order kinetic, obey to Michel-Menton kinetic velocity equation. This equation refers to the metabolism of drugs through first order kinetic and zero order kinetic. This equation or velocity, which is Michel-Menton enzyme kinetic, for first order kinetic, V equals to rate of drug metabolism, which equals to velocity max, V max, by concentration of drug divided by Michel constant plus concentration of drug. In first order kinetic, usually the concentration of drug is smaller than Michel constant velocity. So for first order kinetic, V equal to rate of drug metabolism, which is equal to V max time concentration divided by Michel constant, which is the substrate rate concentration and half-life of velocity. This is for first order kinetic, which is not dependent on drug concentration. And here always the concentration is smaller than Km or Michel constant, so the equation will be, or the velocity will be Vmax time or multiply by concentration divided by Km. But for zero order kinetic, where most of the drug or concentration of the drugs is more than or bigger, larger than Michel constant, so the velocity or rate of drug metabolism will equal to Vmax times concentration divided by concentration, because in zero order kinetic, as you said, it's not dependent on the concentration of drug, and here the Km will be smaller than the concentrations. And the concentration will be higher. For examples, in some drugs, and we note here with the with the most drugs, the plasma drug concentration is less than Km, and drug elimination is first order, that is proportional to the drug dose. With a few drugs such as aspirin, ethanol, phenytoin, the doses are very large. Therefore, the plasma drug concentration is much greater than Km, which is Michel constant, and the drug metabolism is zero order, that is constant and independent of the drug dose. Reaction of drug metabolism. The kidney cannot efficiently excrete lipophilic drugs that readily cross cell membrane and are reabsorbed in the distal convoluted tubules. Therefore, lipid-soluble agents are first metabolized into more polar hydrophilic substance in liver via two general sets of reaction, which is called phase 1 reactions and phase 2. Phase 1 reactions also involve oxidation reduction and hydrolysis of drugs, while phase 2 reaction involve with conjugation of drugs. And we will be talking about each phase in details. These figures explain about phase 1 and phase 2 reaction. And we have to note that all drugs undergo phase 1, not all drugs, undergo phase 1 and phase 2 metabolism in that order. Sometimes the order is reversed. And for phase 1 drug, lipophilic drug undergo phase 1 metabolism, and it will be oxidized and reduction and hydrolysis polar, then to undergo phase 2 and then conjugate. Some drugs directly enter phase 2 metabolism, go directly to phase 2 without past phase 1. Following phase 1, the drug may be activated unchanged or most often inactivated. And some drugs, as we said, directly enter phase 2 metabolism, while some drugs undergo the order phase 1, and some drugs go directly to phase 2. In phase 2, there will be conjugated. A drug is usually here the conjugation product, which is usually inactive drugs, And this figure will show the biotransformations of drug regarding to phase 1 and phase 2. Now, in details, for phase 1 metabolism, conversion of lipophilic molecule into more polar molecule by unmasking or adding a polar group like OH or NH2. Here, phase 1 metabolism divided to phase 1 reaction involving B450 enzyme, which is the cytochrome enzyme, which is most frequent for phase 1 drug metabolism. And also there is not involving the cytochrome B450, example esterases and hydrolysis. And now we will explaining phase 1 reaction utilizing the cytochrome B450 system. Okay. Phase 1 reaction most frequently involved in drug metabolism are catalyzed by the cytochrome B450, which is important for the metabolism of many endogenous compounds such as steroid, lipid, and for biotransformation of exogenous substances such as drug, carcinogenesis, and environmental pollutants. So cytochrome is a superfamily of hemo-containing isoenzyme located in most cells, but primary in liver and GI tract. So this cytochrome, as we said, is very important for metabolism of endogenous and some exogenous substances. In some cases, for an individual drug, some individual drugs may be substrate for more than one isozyme. There is 4 isozymes, which is cytochrome B3A, 4 to 5, cytochrome 2D6, cytochrome 2C8 to 9, and cytochrome B1A2, which are responsible for the vast majority of cytochrome 450 catalyzed reactions. Considerable amount of cytochrome 3A4 are found in intestinal mucosa, accounting for first-pass metabolism of a drug, such as chlorpromazine and clonazepam, as an example. So the cytochrome B450, it is genetically variable. There is variation or genetic variations in the cytochrome B450. So the activity may alter a drug's efficacy and the risk of over or adverse events or toxicity risk. For the cytochrome BD26D particularly has been shown to exhibit genetic polymorphism. As an example for genetically variable for cytochrome, we particularly for cytochrome B26D, which is exhibit genetic polymorphism and mutation in sometimes. So the variation or genetic variation in cytochrome could be altered drug efficacy and altered toxicity of drug. Inducer. Which is increased metabolism, or when this enzyme or this cytochrome the cytochrome B450 dependent enzymes are an important target for pharmacokinetic drug interactions. It's very important for pharmacokinetic drug interaction. One such interaction is the induction of selected cytochrome isoenzyme. When this enzyme is effect on a drug's metabolism, and it's also very important for a drug interactions. It will also decrease the plasma concentrations of the drug. It decreases therapeutic effect, decrease drug activity if metabolite is inactive, and it will cause increased drug activity if metabolite is active. So this cytochrome is, as we said, is very important in the inducer enzymes and will be effect in drug interactions and causes these steps. Could be decreased plasma concentration, decreased therapeutic effect, decreased drug activity, or increased drug activity. And we give as an example for genetic variation, cytochrome BD6 is a particular exhibit genetic polymorphism, and the mutation result in very low capacity to metabolize substrate. For example, some individuals obtain no benefit from the opioid analgesic codeine because they lack the cytochrome D6 enzyme that activate the drug. Also, cytochrome B450 inhibitors act as inhibitor enzyme. So inhibitor cause also a drug interaction and can cause adverse reaction. For example, grapefruit and its juice can inhibit cytochrome B3A4, leading to increased level of the drug metabolized by this enzyme, causing higher therapeutic or toxic effect. Also, another example, omeprazole is a potent inhibitor of the 3 cytochrome isoenzymes involved in warfarin metabolism. When taken with omeprazole, plasma concentration of warfarin increase, which lead to greater anticoagulant effect and increased risk of bleeding. The more important cytochrome inhibitors are erythromycin, ketoconazole, and ritonavir because they each inhibit several cytochrome isoenzymes. And these figure for human cytochrome B450 and their relative contribution to hepatic drugs metabolism. They say that 60% of the drug are metabolized primarily by cytochromes. For phase 2 metabolism, which is involved as a conjugation reaction. Phase 2 metabolism or this process consists of conjugation reaction. If the metabolism from phase 1 metabolism is sufficiently polar, it can be excreted by the kidney. However, many phase 1 metabolites are too lipophilic, then they undergo conjugation reaction with endogenous substance, such as glucuronic acid, sulfuric acid, acetic acid, and amino acid, which result in polar, usually more water-soluble compounds that are often therapeutically inactive. An exception, which is morphine 6-glucuronide, which is more potent than morphine glucuronidation than morphine. So glucuronidation is the most common and the most important conjugation reaction. Drugs already passing an OH or NH2 or COOH group may enter phase 2 directly and become conjugated without prior phase 1 metabolism, as we mentioned that in the previous figure. So the highly polar drug conjugated and then excreted by the kidney or in bile. This is regarding to phase 2 metabolism. Okay, now we are talking about the last steps of pharmacokinetic, which is excretion. Excretion. A drug could be excreted by kidney or by other routes. The drug excretion by the kidney, which is the most important route for drug removable from the body, is through through the kidney into the urine. Drugs need to be polar enough for efficient excretion. So elimination through renal through the kidney into the urine involves 3 processes: glomerular filtration, proximal tubular secretion, and distal tubular reabsorption. And this is the glomeruli, and this is Bowman capsules, which is a part of the glomeruli. And this is the proximal tubules. This is lobophenol, and this is the distal tubules. So the excretion of the drug through the kidney will pass through these parts of the kidney, which undergo glomerular filtration, proximal tubular secretion, and distal tubular reabsorption. For glomerular filtrations, drug enter the kidney through renal arteries, which divide to form of a glomerular capillary plexus. Free drug, which is non-protein bound, flows into Bowman space as a part of a glomerular filtrate, and the volume of glomerular filtration rate is about 125 ml per minute. Lipid solubility and pH do not influence glomerular filtration rates, so will not affect on the filtration rate. For in the part of a proximal tubular secretion occur in the proximal tubules by 2 entry requiring active transport system. Here we need active transport system. One for anions, which is deprotonated form of weak acid, and one for cation protonated forms of weak bases. And in case of distal tubular reabsorption, as a drug moves toward distal tubular reabsorption, its concentration becomes higher than in the perivascular space, and charged drugs will diffuse out of the nephric lumen to the systemic circulations. In distal tubular reabsorption, increasing the ionized form of the drug in the lumen by changing the pH of the urine can minimize the back diffusion and increase clearance. So here there will be increase the ionized form of the drug in the lumen, but change the pH of the urine, changing the pH of the urine in the distal tubule, which can minimize the back diffusion and increase clearance. We have here what is called ion trapping. ion trapping. What is ion trapping and why it's happening? For example, elimination of weak acid can be increased by alkalization of the urine. Elimination of weak acid can be increased by alkalization of the urine. For example, for patients taking phenobarbital in overdose, which is a weak acid, alkalization of the urine with bicarbonate keeps the drug ionized. In case of patient taking phenobarbital overdose, which is a weak acid, we can alkalization urine by using bicarbonate, which keeps the drug ionized and then excrete. For elimination of weak bases can be enhanced by acidification of the urine. For example, in patient take overdose of amphetamine, which is a weak base, acidification of the urine with NH4Cl cause the protonation of the drug and enhancement of its excretion. Enhancement of its excretion. So, as a general rule, weak acid can be eliminated by alkalization of the urine, whereas elimination of weak bases may be increased by acidification of the urine. And this process is called ion trapping. Ion trapping. And this is two examples of ion trapping. Rule of drug metabolism in elimination. Most drugs are lipid soluble. Without chemical modification, drugs would diffuse back from the kidney lumen when their concentration is higher. So, without chemical and most drugs without chemical modification or lipid soluble drug would diffuse back from the kidney lumen when their concentration is higher there. To minimize reabsorption, drugs are modified mainly in liver to more polar compound to enhance its excretion or elimination. There is also excretion by other routes and other parts of the body. Could be by liver, via feces, through lung, and also via breast milk. Through liver contributes to drugs loose through metabolism and or excretion into the bile. In patients with renal failure may benefit from drugs excreted through these routes. Through feces, elimination of unabsorbed orally ingested drug, and for elimination of drugs that are secreted directly into the intestine or bile. Through lung, elimination of anesthetic gases happen through lung, for example, halothane and isoflurane. Through also breast milk, source of desired effect to the infant. So we use drug clearance or excretion through breast milk. Total body clearance. Total body or systemic clearance, which is CL total, is the summation of the clearance from the various drug metabolism and drug elimination organs. The kidney is often the major organ of excretion. However, the liver also contributes to drug loose through metabolism and or excretion into the bile. A patient in renal failure may sometimes benefit from a drug that excretes by this way into the intestine, feces, rather than through the kidney. Some drug may also be reabsorbed through the enterohepatic circulation, that prolonging their half-life. Total clearance can be calculated by using the following equation, which is total clearance of the drug, equal to hepatic clearance plus renal clearance plus pulmonary clearance plus other clearance, whereas hepatic clearance plus renal clearance are typically the most important. The half-life of drugs can be altered by diminish renal or hepatic flow, which cause increased half-life. For example, cardiogenic shock or patient with heart failure or in case of hemorrhage. Decrease the ability to extract drug from plasma will increase the half-life in case of renal disease. Decrease metabolism, increase the half-life. And also it will, some cases, decrease the half-life of drugs, such as increase in hepatic blood flow, decrease protein binding, and increase metabolism. All this what we have about metabolism. Thank you for listening.